Hi everyone, it's your friend Doris the Coder back with another video. If you are new to my channel, welcome. If you are just coming back, thanks for coming back. Today's video, I'm going to cover 5 tips for proper billing, reporting, and prompt payment of planar blocks. Now, you might know some of these planar blocks, even though you think that's a newer term. Things like iPACK. Does iPACK have you wanting to pack it up and leave? Are you feeling SPANK by SPANK blocks? Are you just ready to tap out and quit coding because of tap blocks? All of these are planar blocks that we're going to discuss today. First, let's help you demarcate between what a planar block is versus a plain nerve block. Now, I won't duplicate some of the information that I've already covered in part 1 of the video, so if you check this channel somewhere, you'll actually find getting unblocked on nerve blocks. So I won't repeat that, but generally, your planar blocks are blocks where physicians will take a large bolus of medication, and instead of what we see in a femoral or a brachial plexus or a sciatic, where there is a specific nerve that is targeted, a perineural area that's targeted, a tap block actually looks to target multiple nerves with a single shot, but the providers are not kind of going in and out and going different places. It's a huge bolus of medication that goes in placed very strategically into certain anatomic areas for purposes of nerve blocks. Why these are different than what we've done before is typically the providers are targeting a specific nerve, and these they're targeting a series of nerves. So that is the difference between your planar block. They're actually put into the fascial plane because the fascial planes kind of, the nerves actually exit the fascial plane. So if you want to get a really good distribution of nerve spread, they actually inject into the fascial plane. Now, what planar blocks are not, they are not nerve injections. Clarify that for coders. We think, okay, what nerve did they inject? I used to ask my doctor, well, what nerve are you injecting? What nerve are you injecting? They never inject nerves. They inject around the perineural area. So they're not injections into the nerve. They're injected around the nerve or perineural. They are not intramuscular injections. In fact, they don't want to get in the muscle. They use sonography to get into the proper structure that is the fascial plane. So if your provider's really detailed in your note, you might see the term unzippering as they talk about, or hydrodissection, right? That's where they're letting you know they've gotten into the right place. And these are not 64450s according to the guidance we have in our December 22 CPT assistant. So now we know what they are not. We know how we can actually properly report these services. So how we're going to report these for services, let's first start. Tip 1, how do I code it? First thing, you're going to use CPT code 64999. That is an unlisted code. Unlisted codes don't have a unique description. Amy Turner of Ventura Health actually made a really great suggestion in your practice management systems because 64999 could be a spine surgery or it could be a nerve block or anything kind of in between. In your system, it's a really good idea if you use dummy codes or pseudo codes. Now, what will bill on the claim is going to be 64999, but internally, you want to be able to track your payments and specify how many of each of those kinds of services you're performing. So definitely make sure you code it properly. So 64999. Now, planar blocks, and again, I think we're probably a good 2 years out before we really start to see codes for these blocks. We've got to have participation by anesthesia and the providers that are actually doing these blocks, which are typically regional anesthesiologists, to participate so they're valued properly and we have the proper descriptions. Since they've started using ultrasonography for these blocks, you're just kind of seeing so many blocks that we've never kind of heard of, right? Quadratus lumborums, PEX 1, PEX 2, and all these new ones that come because it's an advance in the field of medicine with these techniques. So you do get to report 64999. Planar blocks cannot be done without ultrasonography. That's how they do sonoanatomy. They determine the structures that they're targeting by using ultrasonography. But 64999 being an unlisted code does not have any description, nor does it have a package. So you will still be able to, just like some of the nerve blocks that they allow us to report guidance for still here in 2023, it's March 2023 at the time of this video, you also get to report your ultrasound guidance with the 64999. Until they give it value and unique classification, you're going to need at least 2 codes for those planar blocks. One 64999 to specify what nerve you're doing, even though it doesn't have specificity, and then the ultrasonography code with the modifier 26 or not based on what your reporting circumstances are. So that's tip 1, code it properly, 64999. Tip 2, you need to work with your providers. Now, when you're getting coding guidance, remember things like the CPT assistant, it's published every month. Payers don't update their policies every month. So when you're reporting and you're following the CPT guidance, you may have to actually educate a payer, right? Or a payer may have guidance saying this is how you report this code because CPT hadn't given guidance on that specific code just yet. So again, you'll need to follow your payer policies and maybe even follow CPT guidance and appeal that through your payer to say, hey, this is why we're reporting these this way. And this is what's proper according to the author of who actually writes the codes, which is the AMA and the CPT. So once you want to work with your provider, the reason you're doing that is you need to find out what structures they're doing specifically. We have codes with value that have already gone through the RUC committee that have allowables tied to them. We can't use those codes anymore, but you want to provide your physician with a list of those codes so they can tell you what is this procedure like, right? So if you had to think about the language I have with my providers is if you had to think about the technical work, right, of accomplishing these procedures and the structures that are at risk, right? Certain approaches cause risks that other approaches don't, right? How long the procedure took and the technical intensity. With this list of codes, what is this procedure like? And I'd like the providers to tell me it's equal to this particular CPT code that's established, right? This procedure, and this is why, or it's like this one, but it's more complicated because of. And then if it's more complicated or less complicated than the established CPT code, I want an approximation about how much more or how much less complicated that is. Once I have that, that's going to take me to my part 3, set the price, right? When I set the price, I'm going to set the price based on the clinical logic my provider has given me. So if, for example, it's a femoral nerve block, single shot, 64447, and the provider says, yeah, it's just like that one, but it's probably 20% more difficult, I am going to set the price for that 64999 at 120% of my billing or allowable for 64447. You see why I need my provider help on that, because I don't want to undervalue the work, which is the entire reason the AMA was queried on the use of 64450, because looking at the RVUs and the work and the things at risk, 64450 certainly doesn't support reporting when we think about the risk from a RUC, an RVU perspective. Just a lot of these planar blocks based on the structures there. So that's going to help me set my price. Once I have my price, I then get to do my letter. And in that letter, which I'm also going to attach my report when I sit it, but the report, procedure report, is not a substitution for the special report or letter that goes with it. And a lot of folks don't like to bill 64999 or any unlisted codes because they're not easy to be paid. And the reason they're usually not paid easily is we're not giving all the information necessary. We're sending the note, we're putting our price and expecting the payer to just figure it out. Not exactly a clean claim. When you do the letter with the data that we've gotten from the provider, right, and we draft that letter and we do our requests and attach the claim and make sure that matches everything, we have created a clean claim situation. I've given you all the information you need. I've done a special report. I submitted the claim. I submitted the note that goes with it, and there's no reason not to pay me. Word of caution, be careful how you price. If you're saying it's 20% more complex than a femoral nerve block, but your price is 20 times or 10 times the allowable, that's going to cause pause. So make sure you're doing it reasonably in your billing and your processing, so it just doesn't unnecessarily delay your claim. And then your last step is going to be to follow up. And this is why it's really important that you have the dummy codes in your system and put these in a tickler so you can evaluate, are you being paid according to what you're billing? Are your letters working, right? Is the payer, do you need to maybe get these in mass and the payer hasn't paid several of these? I can tell you these blocks are not going away. They're actually becoming a different kind of standard of care, having ultrasonography available and using sonoanatomy. We're going to see more of these. If you haven't seen them yet, you're going to see them, and you're going to see more of them because medicine is kind of changing. That's why we're seeing more guidance being billed by providers and them using ultrasound guidance, because that's how medicine is kind of changing. It's more accurate for them to identify the structures that they are injecting or targeting, I should say, because they don't inject nerves, like I said. So those are your 5 steps. If you want to ensure you are coding properly, billing properly, and you are paid promptly for these planar blocks, make sure you follow code it properly, work with your provider, set your prices if you can within your system, including that with dummy codes. Make sure you do a letter, and once you do the letter once, you don't have to do the letter again. You can have templates saved and they can automatically go with the claim for each one of those claims every time you render that service. And the 5th one is follow up. So I hope you found this video helpful. Again, if you use the part 1 that's somewhere on my channel, you'll find some of the precursor work that you want to probably go through to kind of understand anything not covered here. I've got some great resources there. I will also include them here for regional anesthesiology and pain. They have visual references and videos for a lot of these planar blocks, as well as just different nerve blocks, so you can understand what the risks are associated with these blocks, how they're performed, and why they're done. So I am your friend Doris the Coder, signing out until the next video. And you know what I say, like it if you do. If you know someone that can benefit from the information, feel free to share it, and comment, subscribe, tell me what you think about it. One more thing I almost forgot. If you are in Florida in the field of anesthesia, I will also try to link here the FAAA, the Florida Anesthesia Administrators Association meeting. It is in conjunction with the Florida Society for Anesthesiology meeting. We'll be talking deeper about these blocks, planar blocks, as well as critical care reporting and a lot of different topics. So I'll put the information. Love to see you there. Join us. Come up, say hi. We'd love to know how we can support you there. And until the next video, I will see you then. I'm signing out.